So welcome everyone. It's a pleasure to have you tonight or this morning for the people of America. Following our series of webinar on hyaluronic acid, we have the immense pleasure today to welcome Professor Anton Sculean. Hello, Professor. So
hello
what
to
we will
everybody.
do is so I will basically start by introducing your track record on the next slide. I'll let you click on the next slide. Very well.
The next one.
So, as many of you know,
yeah,
exactly, this one.
Yeah.
The one with you, exactly. So, as many of you know, Professor Sculean is professor and chairman of the Department of Periodontology and currently the executive director of the School of Dental Medicine at the University of Bern in Switzerland. Professor Sculean has authored more than 370 articles in peer-reviewed journals, 30 chapters in periodontal textbooks, and has delivered more than 500 lectures nationally and internationally. He's the editor of the book Periodontal Regenerative Therapy and guest editor of the Periodontology 2000 issue, entitled Wound Healing in Periodontology and Implantology. Professor Sculean serves on the editorial board of 12 dental journals and is associate editor of Quintessence International, Clinical Oral Investigations, and editor-in-chief of Oral Health and Preventive Dentistry. His H index on the Google Scholar is 77 and on Web of Science 56. He has been a recipient of many research awards, among others the Distinguished Scientist Award of the International Association for Dental Research, IADR, the Anthony Rizzo Young Investigator Award of Periodontal Research Group of the IADR, the IADR PRG Award in Regenerative Periodontal Medicine, and the Distinguished Teacher Award of the European Orthodontic Society. Professor Sculean is past president of the Periodontal Research Group of the IADR, of the Swiss Society of Periodontology, and of the European Federation of Periodontology, EFP. Currently, he is the president of the International Academy of Periodontology. His research interests focus on periodontal wound healing, regenerative and plastic aesthetic periodontal therapy, use of antibiotics, antiseptics, and novel approaches such as laser and photodynamic therapy in the treatment of periodontal and peri-implant infections. Of course, for us at REGEDENT, it's an immense pleasure to have a caliber like yours presenting and taking us through the clinical evidence related to some of our products. I'll leave you the stage, even though it's virtual.
Thank you very much, Alexandre, for the introduction. And I'm very pleased to have the possibility to share with you some of our data on this interesting material and also elaborate on the potential clinical relevance and applications. So in my topic, I will talk first of all about the biology of using some biomaterials in periodontal wound healing and regeneration. What is the preclinical evidence that we have on hyaluronic acid? And I would like to share with you some of our clinical cases and clinical experience before coming to some conclusions. So I think it is very important to go back in the literature and to point out that this is not a new material because as you can see it on this slide, this material has been described already in 1934 by Karl Mayer and co-workers. And it was first extracted from the bovine vitreous body. And that's why it is also called hyaluronic acid. And in fact, if we look at the chemistry of this molecule, it is a large polymeric glycosaminoglycan, and it accumulates in the extracellular matrix in the wounds. And immediately after wounding, we have a very high concentration of these molecules, and it peaks after about 5 days. And of course, we have a long and short chain hyaluronic acid, and it is a whole science behind it. I don't have the time to elaborate on all details, but of course, some of the chains may have a inhibitory effect, and some others a proliferative effect on the various cells. So if I would summarize that what we know nowadays about this material in wound healing, we know that it reduces inflammation, it promotes cell migration into the wound. In other words, it also induces MMPs. This is matrix or matrix metalloproteinases. It modulates cell proliferation, and it interacts with growth factors, most importantly with TGF-beta1. And it also helps diffusion of nutrients and other molecules in the wound area. And it has a positive effect on scarring. In other words, it suppresses scar formation, and it induces some release of bioactive molecules. We looked, first of all, with our research group in Bern on some biologic effects of this material, because always when we start to use a material in our patients, I am very fond of looking into the details. I think it's very important to understand the mechanism of a material and not to use just blindly anything what is given to us from the industry. I think it's very important to be critical. So we started from scratch. We looked upon the biology of the material in the cell biology laboratory, and we wanted to see whether hyaluronan stimulates wound healing potential of fibroblasts, especially fibroblasts from the periodontal ligament and the fibroblasts from the gingival connective tissue. And we did a lot of studies and experiments in order to find out some biologic effects. So we looked at two different preparations. One is a native non-cross-linked a molecule. The second one is a cross-linked molecule. And most importantly, the two preparations did not have any negative effects on fibroblasts from the periodontal ligament and from the gingival connective tissue. Then in another experiment, we looked at the proliferation of these cells. And you can see the curves, the two curves, the green and the red one, and compare them to the black one that is the control. And you can observe that by applying these molecules on the cells, we have a very strong effect on the proliferation rate on both types of cells. And then if we look now at the migration and proliferation of those cells, you can observe it on the two slides. You see the plates, the control, and following the application of the two different formulations. You see that the number of cells increases significantly when they interacted with these materials compared to the control, indicating that we have a positive effect on the migration and proliferation of human periodontal ligament and gingival fibroblasts. Then, of course, we looked at some other aspects like release, for example, from different growth factors. And again, if you look at the slides, I don't want to go into all details, we can see that the two formulations have a strong effect on the production of growth factors, especially the growth factors that belong to the group of transforming growth factor beta. And again, if you look now at some other growth factors, for example, PDGF, you can see the same. If you look at FGF2, this is fibroblast growth factor, or epidermal growth factor, you can see the differences between the two formulations and the control. The control is always the black part, indicating quite impressive biologic activity of this material on the cells. And if you look now at some other pro-inflammatory cytokines, again, the tendency is the same. And this was a quite important finding of this study. Again, if you look at some other cytokines and MMPs like MMP1, MMP2, MMP3, MMP8, again, we see the differences between the control and the two tests. In conclusion, we were able to say that the material is fully biocompatible, no negative effects on the viability of these soft tissue cells. It has an important effect on the proliferation and migration of periodontal ligament and gingival connective tissue cells. And it has also an important effect on the indicators, some molecules that have a very important role in the scarless wound healing, like, for example, TGF-beta3. It also upregulates the expression of genes encoding certain growth factors that are important for proper wound healing. And it has also a certain release in pro-inflammatory cytokine gene expressions. In other words, it initiates cellular inflammatory response. And it has an important effect on the remodeling of extracellular matrix. And then we also looked in a second study that was published only 1 month ago on the effect of bone cells. That means on either mesenchymal stromal cells and pre-osteoblasts or also osteoblasts. And again, we performed a series of studies because we wanted to see, do we also have a certain effect on hard tissue cells? And you can see the two types of cells. They are stromal precursors of bone formation. And again, if you look at the curves, the green and the red one, and you compare them to the black curve, you see a big difference, indicating also an effect on these cells. And again, if you look at some expression of genes that encode bone matrix proteins, you see again a difference, indicating that we also have a certain effect on bone or precursors of bone forming cells. However, we also found out that it has an inhibitory effect on mineralization. In other words, the cells appear to maintain their stemness over time. And this is very important because it has an effect on the proliferation of those cells. However, the mineralization is inhibited. In other words, it may keep the stemness of the cells, and these cells may differentiate in different directions over time. And then we moved on in some preclinical studies in animals with our collaborators from Japan, with Dr. Yoshinari Shirakata from Kagoshima University. And we wanted to see whether the effects, the healing, may be also affected in different periodontal defects. So we moved on in an experimental study in animal models, in dogs. And you can see that following tooth extraction, and the remaining teeth, intrabony defects were created. Then these defects were, of course, standardized, and they were following creation, they were treated in 4 different ways. Open flap debridement, of course, serving as control. Then we use a certain type of collagen matrix sponge that may stabilize the blood clot. We used the hyaluronic acid. We used the cross-link type that was tested previously in cell cultures. And then we used also a combination of the hyaluronic acid and the collagen matrix. Please have a look at these box type of defects that were described in the literature. They are so-called non-contained defects. And you see to the left, one open flap debridement, an empty box, then application of hyaluronic acid, then open flap debridement and the combination of collagen matrix and hyaluronic acid and the collagen matrix alone. Please have a look at the wound healing in the different groups. The wound healing was always very nice. And then we performed the histology. And the histologic evaluation was quite interesting. Now you can see a defect that was treated in an open flap debridement. Along the root surface, please observe proliferation of the epithelium. And you can see this very nicely to the left, almost until the most apical part of the defect. Some bone remodeling can be observed in an apical part. However, between the bone and between the root surface, we have an epithelial layer, indicating more or less a kind of reparative type of healing. Then, if we look now at the next slide, and we look at the formation of the different periodontal tissues after placement of hyaluronic acid, please observe a very, very nice formation of new cementum, periodontal ligament and bone. And if you have a look at the slide to the middle, you see the new cementum with inserting collagen fibers and newly formed bone. And the newly formed bone is very nicely connected to the cementum via sharp ice fiber. And of course, if we look at the combination of the collagen matrix, the collagen sponge, and we look at the combination with hyaluronic acid, we see very nicely also a healing indicating periodontal regeneration and formation of cementum, periodontal ligament, and bone. And now if we look at the histomorphometric analysis, we can very nicely observe that compared to the control group, the application of hyaluronic acid or the hyaluronic acid and the collagen matrix resulted in significantly higher amount of new cementum. Also, the collagen matrix had a positive effect on the stabilization of the blood clot. The best outcome was obtained in the combination group. That means the collagen matrix and the hyaluronic acid, indicating that we may have a very good effect when we combine a collagen sponge that is stable together with this biologic activity. And of course, if you compare the results to those obtained in the control group, there's a difference. So we concluded that using this material, we may have a higher chance to regenerate periodontal ligament and root cementum in two-wall intrabony defects. And then, of course, we moved on. We moved on with the next study that elaborated on the potential application of this material on recessions, because we have a very important aspect when we treat soft tissue defects, that means gingival recessions. However, before I would apply this material, I would like to know what is happening on the debrided root surface. Can we obtain a certain periodontal regeneration on recession? And again, with our friends from Japan, we designed a very simple experiment. Recession type defects were created, of course, standardized recession type defects, and they were treated after a certain chronification period with two different approaches. Coronally advanced flap alone, serving as control, or coronally advanced flap combined with hyaluronic acid. We always use the same type of material. And of course, you can see the histometric analysis and measurements that were performed after about 10 weeks of healing. And let me show you some slides. This is an example of a test and a control. Please observe the recession type defect. In the upper slides, you can see the application of hyaluronic acid and the coronal positioning of the flap. And you can also see the corresponding control. And now if we go to the healing, please observe the slides in the upper row indicating the healing after application of hyaluronic acid. Please observe that coronally to the notch, we observe formation of cementum, periodontal ligament, and some bone. This is the test group. If you go in the lower row, you see to the left the clinical outcome that looks nice in both groups. However, histologically, we clearly observe a long junction epithelium and no periodontal regeneration. And again, if I would look at the clinical measurements, I see that we have, in terms of clinical attachment level, a higher improvement in the test group compared to the control one. And again, I show you some other slides. This is a representative control slide. Please observe some very minute bone formation located in the apical part of the defect. And if I look at representative or some representative test slides, please observe more bone formation coronally to the notch, more cementum formation, and another representative image indicating a very impressive formation of periodontal ligament, cementum, and bone, which is, of course, the proof for periodontal regeneration. And this is, dear colleagues, the first study that has demonstrated periodontal regeneration in animals using hyaluronic acid in both recession and intrabony defects. And now if you look at the histometric measurements, please observe the differences in terms of new cementum and new bone formation in the two groups. Between the test and the control, you can clearly observe a difference. And now let me show you what we know from the literature, because I think it's also important to look what other research groups have done. So we performed systematic review and meta-analysis, and our goal was to try to find out, do we have some evidence from the literature that these materials may have a positive effect on the healing? And we looked at the data in intrabony defects. In intrabony defects, if open flap debridement is performed alone or by adding hyaluronic acid, in terms of clinical attachment level, we found still significant improvements. And if you look at probing depth reduction, again the same, statistically significant benefit for the application of hyaluronic acid. So in conclusion, in intrabony defects, the application of hyaluronic acid may additionally improve the outcome of periodontal surgery. So then we moved on, and I treated more than 80 patients with single or multiple recessions, because my wish is to have a material that we can use in order to treat soft tissue defects. So what is the indication to treat gingival recessions? Of course, if I'm the lower jaw, I would like to help my patient to perform a proper oral hygiene, in other words, to prevent gingivitis and root caries. If we are more in the maxillary arch, I would like to improve the aesthetics. In some cases, we may also improve hypersensitivity. So if I would show you some cases, this is my routine patient in the daily practice, mainly a patient with a post-orthodontic situation. Sometimes we have an active retainer, then we have to consult with the orthodontist. And you can see the problem. The patient has difficulties in cleaning. She has gingivitis, no stable soft tissue. In other words, we have a lack of attached gingiva and an inserting frenulum. And in some specific cases, the situation may even deteriorate further. And we can also, in some cases, even lose the tooth. You can observe this deep pocket that developed in the lingual part of this recession. So, of course, we always start with the etiology. We try to find out what is the cause of the problem. However, we have to move on also to the treatment. And for us as a clinician, it is very important to focus on the biology of periodontal wound healing and regeneration. It is very important to understand that we need to stabilize the wound. And the phases in terms of wound healing are always the same. Doesn't matter if I have a non-surgical approach, surgical approach, recession coverage, whatsoever. We always have the inflammation, we have the formation of granulation tissue and the matrix formation of remodeling. And this very important part of the wound healing is located in the first 2 to 3 weeks after surgery. And we aim with our surgery, with our surgical technique, with our regenerative material, with our connective tissue graft or collagen matrices to improve and help the body to heal during this first phase of healing. So what is now the treatment concept? We would like to use flat designs that aim to enhance wound stability by avoiding vertical releasing incisions as much as possible. Of course, I would like to use some biologic materials that have a potential to enhance periodontal wound healing and regeneration. Very often the tissue is very, very thin. So in other words, we need to increase the tissue thickness and to improve stability. I would like to use subepithelial connective tissue grafts or soft tissue replacement grafts in order to enhance soft tissue thickness and enhance wound stability. And then, of course, a tension-free flap adaptation and suturing is mandatory. So we start to focus since many years on the tunneling approach, and we modified it in a certain way. First of all, we know that we have some advantages with this technique. Why? Because we do not have vertical releasing incision. In other words, we may stabilize the tissue. We have less scar tissue formation. But with our technique, we always start with a full thickness preparation because the tissue is very, very thin very often. And what I need to have is a stability of the soft tissue and the certain thickness. I would like to enhance vascularization. With this technique, we have a very good survival potential for the graft and a very nice increase in tissue thickness and in the tissue color and blending. Of course, we need specially designed instruments for that, so-called modified tunnel instruments. And let me show you some cases because I think this is what matters nowadays. So we have seen that we have a potential biological activity of hyaluronic acid. Now we have our patient, and of course we need to have also our surgical technique. So in this particular case, we have a post-orthodontic situation and a very, very thin tissue. We have also a certain insertion of the frenula. And what I would like to have is to prepare the flap, the tunnel, in a way I preserve the papillae as good as possible. I have an internal frenulectomy, and then I move the two edges of the tunnel together. And we described together with my friend, Dr. Pat Allen from Texas, from Dallas, this technique, and we called it laterally closed tunnel. So we mobilize the tunnel, we release the fibers apically as much as possible in order to have a tension-free mobilization. Of course, we use a connective tissue graft, especially in the lower jaw. I always prefer a connective tissue graft because we need cells that are able to produce and to regenerate the soft tissue. This is the application of hyaluronic acid, and my experience with this material was very interesting because I observed that the material sticks to the root surface. You can see it very nicely on this slide. So we have a kind of stabilization of the blood clot, which is a quite unique characteristic of the material. And we know from the literature that one molecule of hyaluronic acid can bind about 50 molecules of water. In other words, we do not need to dry the root surface. It's very important. So it works. If we have a bleeding surface, it works even better. And this makes life easier for the clinician. So we place the connective tissue. Then I place another layer of hyaluronic acid. You can see again the same phenomenon. And then with tension-free sutures, I just close laterally, very, very simple procedure, and wait for the healing. This is the situation baseline. This is after about 2 years later. You see a very nice regeneration of the soft tissue. We don't see scar tissue formation. Another case, this is already a Miller class 3 defect, so we cannot regenerate the papillae. Nowadays, according to the new classification, we call it class 2. So again, the same procedure, preparing the tunnel, preserving the papillae, making sure that I have enough space for my connective tissue graft, but a tension-free preparation of the wound edges is very important. Again, please observe the characteristics of the material. It sticks to the root surface. And then we place the connective tissue. And the big advantage of the connective tissue is that in the event, it is not completely covered. It still has the potential to keratinize. And this is very important. In other words, 1/3 of the connective tissue can be left exposed, and 2/3 should be submerged and fixed. I like to use sling sutures for this. Please observe the outcome, a very nice healing, no scar tissue formation, and we have a complete coverage in this so-called class 2 or Miller class 3 recession. And then let me show another case. Here we have recessions located in the maxillary arch. Again, the same technique, mobilizing the tunnel, applying the hyaluronic acid, moving the flap in order to cover the connective tissue graft. And then we have a very nice and tension-free coverage. Usually I like to leave the sutures for 2 or nowadays even 3 weeks in order to be sure that I have a good wound stability. Please observe the outcome, complete coverage, and absolutely no scar tissue formation. And sometimes we have even more difficult cases, as you can see it here. This is a young lady that underwent orthodontic therapy. And please observe the situation. Here we have about 7-8 millimeter recession depth. However, we also observe a difference between the height of the 2 central incisors. In such a case, I always consult with my orthodontist. It's very, very important to work together. In this case, I did it with Dr. Gnatidis from the orthodontic department and Professor Katsaros, because we work very closely together. And this is very, very important to find out the reason of the problem. And you see that this twisted retainer can create a problem. So it can be active. And in such a case, we always need to readjust the position of the tooth. And just by moving the tooth a little bit more lingually, we can already improve the soft tissue defect. And this is very important. Never start with a surgery before having a very clear plan in your mind. This is very important. Please observe that the recession itself improves after orthodontic therapy. But this may take 6 months. We have to keep this in mind. This is very important. It's not from one day to the other. And then we have the defect, and now we may go for surgery. However, now the prognosis of our surgery is much, much better. So prepare the flap. Again, the laterally closed tunnel. You see the mobilization of the papillae and the tension-free tunnel preparation, placement of the material onto the root surface. You see the stability of the blood clot, again the same. The blood is not flushing out of the defect. This is a very important characteristic. I would like to stress it again. Use the connective tissue graft, fix it exactly at the CG. It's very important that the connective tissue graft doesn't move at all. And then very gently move the edges of the tunnel together, no tension, and leave it here. And this is after about 6 months. And if you look at the case after about 1 year, we have a very, very nice regeneration of the soft tissue. Probing depth is maybe 1 millimeter, but we have a complete regeneration of the soft tissue and no scar tissue formation. And this surgery was done in one single stage. Let me show another case. This is a canine, again, a post-orthodontic situation. However, please observe here the canine is a little bit outside the bony envelope. It was not possible to move the tooth back because of the space and the occlusion. We checked it with the orthodontist, of course. Again, the same procedure. You see the lateral mobility of the flap. Again, the placement of the hyaluronic acid, stabilization of the blood clot, application of the graft, and the suture. We can leave the coronal portion a little bit exposed, doesn't matter, but it has to be stable. And this is a complete regeneration of the soft tissue. Please observe 100% coverage, and we have no scar tissue formation. It looks very natural. And now I would like to show you also a small video on how we do this technique. Please observe a case, again, a lower canine, almost no attached gingiva, maybe 1 millimeter, and a very thin tissue. And here you can see the problem. The tooth is a little bit outside the bony envelope. Of course, we need to consult with the orthodontist. We did it, and it was not possible to move the tooth back. Sometimes we have to make the best of the situation. Of course, I clean the root surface. This is the first step. Then, following intrasulcular incision, I prepare the tunnel. It is a full thickness approach. I always start full thickness, and then passing the mucogingival line, it may become also a split thickness. But at the very beginning, I prefer to go onto the bone because it's easier, and I have less chance to perforate. So this is very important. And I just lift a little bit the papilla. I can use the different tunnel instruments, but also currents. And please observe this movement. This is very important because with this movement, I can remove the frenulum, and I can also remove part of the frenulum. I call this procedure nowadays internal frenulectomy because if possible, I do the frenulectomy in one single stage. And this has the advantage that I will not face scar tissue formation, and I have a very good potential for the healing. Please observe the depth of the defect. It was almost until the apex. So in such a case, I would always advise to use a certain type of regenerative material. We may use enamel-matrix proteins. We may also use hyaluronic acid. However, don't forget that we may have bleeding in a tunnel, and it is more difficult to control compared to a coronal dense flap. For this reason, I try to use this material that may bind the liquids, may bind the fluids, and it interacts positively with the blood. Then, of course, we harvest the connective tissue graft. This is very, very important because I would like to have a very thin graft. The graft should be harvested very close to the epithelium because we need a material that can be adapted like a membrane. And of course, always the largest part of the graft is placed over the recession. Then I apply the material. You can see the typical appearance of the hyaluronic acid. I pull the material into the tunnel. It is very, very important to stretch the graft and to make sure that the graft doesn't rotate in the tunnel. It has to stay over the recession like a membrane. This is very important. And if possible, I prefer to use metal sutures because they stretch better and they stabilize this situation better. And by using my probe and my very tiny elevator, I make sure that the graft is very nicely positioned. I stretch it, but then it is very important to move the graft a little bit more coronally. And the sling suture is very easy to do. I start always lingually. I capture the graft at one of the line angles, move around the tooth, and capture it at the other line angle, the recession, and then move back and tighten it lingually. Usually I use only one suture. It's a 6-0 polypropylene. It's a short needle, maybe 12 millimeter long, because with this needle I can manipulate much better in the lower frontal area. And then I apply a second layer of the material over the connective tissue, and we start moving the part of the tunnel together, starting from apically and moving very, very gently coronally using single interrupted sutures. And I can also combine the single interrupted suture at the neighboring teeth with a sling suture. And this sling suture, for example, is capturing only the soft tissue without passing through the graft. I move always with the reverse part of the needle under the embrasure. Then I make the first knot. And before cutting the suture, if I have a retainer or I have splinted the teeth, I can make a second suture over the retainer. And this will allow for a very, very good stability. This suture will be kept for about 3 weeks. And let me show you the situation at baseline. And this is after about 1 year. Complete coverage of the defect, very nice clinical appearance. The probing depth is maybe 1 millimeter. I have not seen in my patients any residual pocket formation. And we published the first data. It was just published this month, focusing only on lower jaw recessions. Only one surgeon did the surgeries. It was myself. And please observe that the complete root coverage was 50%. In other words, in 50% of the cases, it was covered until the CG. And the mean root coverage was about 96%. This is an excellent outcome, especially in the lower jaw. And then a second paper will appear, I think in the next 1 or 2 weeks. Just send me a message and I can send you the copy of the paper. And there we analyzed the outcomes in multiple defects. And also there we found more than 90% complete coverage. So, dear colleagues, let me come to some conclusions. I would like to conclude with one sentence. I think that this formulation of hyaluronic acid is a useful tool. for being used in conjunction with periodontal surgery, because it may improve periodontal wound healing and even periodontal regeneration, and can be used in the treatment of intrabony defects, maybe combine it with some materials. We have to further elaborate on this issue, but definitely in soft tissue surgery. And with this, dear colleagues, I would like to thank you for attending the webinar. I'm free to ask and to answer, of course, your questions. This is my email address, but I have also, since a month of Facebook, so you can also ask also there a question. And I think you have also free access to this webinar. You can have a look at the address. And now please ask, and I will try to give answer to your questions. Thank you very much again.
Thank you very much, Anton, for this fantastic presentation and sharing all your insights. We have received quite some questions here. I suggest
31 questions, huh?
Yeah, exactly.
Okay.
So maybe let's read loud the question so that the audience can understand the question, and then you can answer it. So the first one is, have been any effect on cell adhesion been observed? Any differences with regards to adhesion depending on cross-linking?
It was difficult to determine because, I mean, cross-linking was more stable, definitely. But also the non-cross-linked had an important effect. But from a clinical point of view, it seems that if you have the cross-linked formulation, it is more stable.
Okay.
Yeah.
Second question, does hyaDENT work better in certain age groups? Are there any limitations regarding the use of hyaDENT in aging patients?
No, I think the most important for a patient is to be healthy. So if a patient is healthy and we do not have a contraindication for any type of oral or periodontal surgery, then age is not a limitation. I mean, I did recession coverage also in a lady that was 82 years old, and I covered the entire maxillary arch, and the healing was fantastic. I mean, this is very individual. Of course, obviously, elderly people take more medications and they have also more diseases. But I think the most important is the general physical health. If the patient is healthy, is no distinction.
Okay, thank you.
Have you tried perimplantitis?
Okay.
Not yet. Is a good idea. We have to do a study.
Okay.
But I think it may have an effect if we are able to clean the surface. Maybe we should start first with mucositis before trying perimplantitis, to look how the material sticks on a titanium surface. And then definitely, of course, we have to remove the biofilm. This is the first step. But then we may need something to reduce the inflammatory response and to enhance soft tissue wound healing. And why not? I think is a very good thought.
Good, thank you. Next question. Good, thank you. What happens if hyaDENT is in contact with blood? Does it affect?
It works even better. So this is one major advantage in the clinics. You don't have to bother whether your root surface is dry or not, because hyaDENT or hyaluronic acid, because hyaDENT is only one product. But if you take hyaluronic acid, these formulations, and you have a fluid, you have blood, it attracts the blood. So in fact, one molecule of hyaluronic acid binds about 50 molecules of water. And for this reason, it is very interesting in the tunneling procedure, because there I always had my personal difficulties in drying the surface. So if you use Emdogain there, it flushes out from the wound, and we have less concentration of enzymatic proteins. So this is, for me, something that also from a clinical point of view was very interesting.
Okay. For patients in need of both non-surgical and surgical therapy, can HA be used in both phases of treatment to enhance the results or the preparatory phase of the surgery?
Yes, I mean, we have also, I didn't present those data, but we have a couple of studies in the literature done with some other products, but also based on hyaluronic acid, that have shown that used in combination with scaling and root planing, that means non-surgical periodontal therapy, we have a certain improvement of probing depth, gaining clinical attachment level, and most importantly, less bleeding on probing. In other words, it positively influences the inflammatory phase. Okay. Then it is possible to explain the suturing technique. You have to attend one of my courses in Bern. We have fantastic courses. You are welcome. I will explain all the details for 4 days. Then
endogain was already covered.
What are differences in clinical outcomes? I mean, we have much more data with endogain, definitely. And I was one of the pioneers working with endogain since 1996. I treated my first cases. It is very difficult to compare because I have much less experience with hyaluronic acid, obviously. In intrabony defects, I don't have cases treated. We have only the animal experiments, but I have many cases treated with for recession coverage. And if I look the cases that I treated with recession coverage, I treated about 80 patients. The results are really fantastic. I would say at least the same for soft tissue. Okay, I want to stress it for soft tissue. Yeah, but we don't have direct comparative studies. Okay, it cannot only extrapolate from my experience.
Okay. Can we use xenograft or allograft instead of CTG if you can reach full coverage of grafts?
Yes, I mean you can combine it with. I mean it's the same like as PRF. Also, if you use PRF, you can use it with a autogenous graft. You can combine it with a collagen matrix, with a membrane whatsoever. I mean, this is just one additional tool. I mean, it will never replace your surgical skills. Never replace a connective tissue graft. It may add some biologic potential to the wound. That's it. Okay. So we need all the components, and hyaluronic acid is one of the components. Okay.
Okay, maybe the two last questions. What would be the rationale if you use a collagen matrix 3D plus HA instead of FGG in Miller type 1 or 2?
I don't know yet. We use the 3D collagen matrix for intrabony defects. That was the fibroguide that we used because it maintains the volume. And we have seen a very nice outcome because we need the space, and not all type of collagens can maintain the space. So that's why I decided to use this one. And it can maintain the space. And I think it depends on the case, because if we have a huge lack of soft tissue, huge lack of keratinized tissue and attached gingiva, then you can never replace the autogenous tissue with a collagen matrix. But if you have, let's say, a middle type of defect with a medium type phenotype, then why not? I think it's a good option. But we still have to learn more about that. I cannot answer you all the questions because I didn't do all the studies, and I can only present what I know. Okay, but I think it's a very interesting approach, and we have to do more research on that. And everybody has to make her or his own experience.
Question related, and maybe the last question related to CTG. Can we use HA alone without a CT graft to treat gingival recession?
Yes, I just answered it, huh? Before. I think yes, if you want, yes. And then, do you have a control group? I mean, in the animal studies, of course, you always had a control group, also in the cell studies, but in the recessions that I treated, these patients are patients sent to me to get the best treatment. Okay, so I try to always provide them the best possible treatment, and if the defect is deep, I always I either use Emdogain and the connective tissue graft, or I use nowadays hyaluronic acid and the connective tissue graft. Of course, you can also use connective tissue graft alone. However, you have a higher chance for an epithelial proliferation and even for a root resorption. That's why I try to combine it with the biologic material. And since these patients are referred to me by the practitioners from Switzerland, I cannot tell them that you are now the control group. But I think if you treat 80 cases and most of them are exhibiting full defect coverage and very minor probing depth, residual probing depth, then it's fine for me. I don't care about the control group because I want to provide the best treatment for my patient. Scientifically, of course, you're right. We should do a study, but the practitioner in the daily practice, he doesn't care about the studies. He wants to have the patient back with a good treatment. Hello from Colombia. Yeah. Simple sutures. I will go to Colombia next year, International Academy of Periodontology, in the last weekend in April, and I will give a hands-on course. So in Cartagena. So if you attend my course, I will teach you the sutures.
Very good, very good. Thank you so much, Professor, for taking time.
Thank you, and enjoy the evening. Okay, stay healthy.
Thank
Muchas
you.
gracias.
Bye,
Bye-bye.
everyone.